Okay, I think we'll get going since we have a lot to pack in for the 90 minutes. Welcome everyone to our second webinar on vaccine confidence in the context of vaccine trials. A bit of a more upstream confidence area than what we talked about in our webinar last week, but an absolutely crucial one, particularly as we're all anticipating hoped for COVID vaccine and the importance around confidence in trials, and also as a number of trials that are ongoing facing some of the challenges of continuing their operations in the context of COVID. So without taking any more time, I just want to thank all of you for signing up. I think we have quite a large group today. This will be recorded. If anyone has any issues about the recording, if your name is mentioned, or just please let us know. Otherwise, the recording of the session will be posted on our website after the session. I'll just quickly walk through after the first talk, after I hand over, will be with one of our senior researchers, Emilie Karafillakis, and she will talk about the social listening, as we call it, that we're doing with social media around a number of trials. This is supporting the MRC funded trials, vaccine trials network. So she'll tell you a bit about what we're doing with that and the approach to trying to, as it were, catch rumors when they're in their earlier stages and try to assess their risk for disruption. And then we'll move into a session on insights from the field. We're thrilled to have Beatriz da Costa Thome from Brazil, who will be talking about the experience in Brazil. I had the honor to work with Beatriz as part of the Nuffield working group. We produced a report called Research in the Context of Global Health Emergencies, particularly from the lens of the ethics. That's available on the Nuffield Trust website. And then we'll hear about some of the challenges in maternal vaccination trials from Nellie Myburgh, who's at WITS in South Africa. Nellie's a social scientist, but when you're a social scientist of trials, you become pretty fluent in the process anyway. And we look forward to hearing from Nellie. And then we'll hear from Primus Chi, who's based in Kenya at the KEMRI-Wellcome Trust site, and he'll talk about some of the perceptions and challenge around the human challenge study approach to trials, which I think will be quite interesting because that's something that has generated some debate, particularly in the area of confidence and the importance of the public understanding the implications. And then we'll go into a more action-oriented, well, they're all action-oriented at different parts of this picture. Some of the proactive communication and community engagement that we have ongoing, more around Ebola vaccine trials, but reflections on what they could lend to other trial processes. And that will be with Robert Kanwagi from World Vision, who's been working as part of a consortium on Ebola vaccine trials, acceptance and delivery, and also Mateus Sahani, who's based in Goma in DRC, and also part of that broader consortium that Robert is working on and that I'm coordinating on the multi-site engagement. Thanks so much. I'll quickly turn over. I won't spend time on the introductions in the course of the session, just to give you the context. So we'll start with Emilie. Thank you.
Hello, everyone. So I'll go very quickly through some of the social listening work that we've been doing at the Vaccine Confidence Project, specifically around vaccine trials. We've sort of acknowledged, we know that rumors can have really a detrimental effect, not only on vaccine programs and vaccines in general, but also on vaccine trials and how vaccine trials are run and participation in those trials. So we've developed a framework that you can see on the slide to try to understand what constitutes a rumor that actually has a potential to disrupt a vaccine trial and which one doesn't. We have a lot of concerns and rumors that can be shared, but that will never actually be picked up and will just sort of stay silent in a way. So it's important to know which ones have a high risk of disrupting trials, to know which ones to focus on in our communication and engagement strategy. So we've developed this framework as part of work that we've been doing with the MRC vaccine networks, Imprint, HIGVAC, and Validate. And we've been monitoring social and digital media for around a year now, trying to detect any rumors and concerns or misinformation that was circulating around vaccine trials. And once we have these rumors detected, we then have a 3-step assessment procedures that we go through. So we first look at what we call rumor prompters. So what is it that might make a rumor start? So is it, for example, new safety data that might be published around a vaccine trial? It could be a new disease that is declared, like COVID-19, for example. It could be any type of event that triggers this initial sharing of a concern or a rumor. The second step is looking at sustaining and amplifying factors. So as I said, some rumors will never get picked up. That could be because they're not shared sufficiently, they're not engaged with. It's about how global they are as well. Is it something that's really just local, that's shared in one Facebook group, but then doesn't go further than that? Or is it actually something discussed in mainstream media? That will then tell us also something about the impact. So have we already seen an impact on vaccine trials, for example? So that helps us, this 3-step assessment, help us then categorize the rumors in green, yellow, or red alert system. And accordingly, we have different actions that we take based on the risk that we've assessed. So it goes from continuous listening to in-depth investigation and more rapid and targeted responses. So I'll go through one example that we've been, and hopefully that will clarify a little bit how we do this. And one example is COVID-19 and what we've been facing in the past few months with the increased spread of rumors around COVID-19, but not only around vaccines in general, but also around vaccine trials. So we've picked up since February 4 key areas of concern, which are listed here. So there's concerns about testing. So the concerns that, trials are being used to experiment on people from low and middle income countries, by Western powers that come into those countries and trial their vaccines, with a fear as well of not having proper consent from participants. There are concerns around sterility, which have been ongoing for many, many years, but we've seen really a resurgence in those in the past few months. Concerns about trials. So we've seen a rise of misinformation and rumors about both COVID-19 trials, but also vaccine trials in general. So these are the 4 key areas that we've really picked up from our social listening in the past few months. So that's the concerns. Now, I talked about the importance of looking at rumor prompters, but we also need to think about the context in which this is taking place. So the rumors we've seen spreading and shared mostly happened in the African region, so in African countries. Not only, it was in other parts as well, but the ones that we found with sterilization and all of that, at least in our social listening, came out mostly in those countries. And if we look at the context, that really does have an influence on how and why these rumors might take hold in some countries more than other. And we know that there's a history of failures of medical experimentation in many countries, with going back from the 1800s with sterilization experiments to even more recent trials with HIV trials or the Trovan trials or malaria. And I'm not going to go into all of these, but these are all cases that have led to an erosion of trust, of public trust in the trials system and how trials are implemented in certain countries. And issues, as I mentioned, we've seen issues around consent. So in many of these trials, participant consent was not taken in the right way, which has led to some questioning around people being used as what they call themselves guinea pigs into the studies. And that's not only related to vaccine trials. We've seen, for example, HPV demonstration projects in India taken as an example of how participant consent is not always done properly. And as I mentioned, also sterilization is a key issue that we see coming back for many, many years. We've seen that with tetanus vaccine in Kenya, but actually not just in Kenya, we've seen that all around the world. We've seen it with polio vaccination, so not just trials, but also vaccine programs. So this is the context that we're dealing with. But what actually happened, what was the event that triggered that increase in rumors, was really, really closely linked to an interview that was done in the French media with two French doctors that was back in April, that claimed that COVID vaccine should be trialed in Africa. So that was what they mentioned in the interview. Now that was taken by social media, Twitter, Facebook, mainstream news, and created really a surge in criticism, but also shared a surge in rumors and misinformation being shared. Obviously, that comes into another context, which is the context of a pandemic that we're actually in. And that means that we are living now in a time of heightened anxiety and panic, which also has the effect of creating an information vacuum in a way, because we don't know everything yet about COVID-19. There's so many information gaps that it's very easy for misinformation and conspiracy theories to take hold and to fill that information gap. So we've seen so many conspiracy theories being shared online, not only about vaccines, but about how to treat COVID, how COVID originated, anything really, that really created an environment of distrust in government, health authorities, science in general. And another interesting point in terms of rumor prompters is 1 week before that interview with the two French doctors was conducted, there was an article published in the BMJ that criticized WHO malaria vaccine studies conducted, mostly they were talking about Kenya, and criticized the fact that consent was not properly taken in those studies. And that, combined with the interview, basically created that rumor storm that we've been able to see. And these are a few graphs from the digital and social listening analysis that we've done. And if you look at the first one, it shows the number of posts and engagement with posts around sterility. So you can clearly see beginning of April, just after the interview, how there has been a surge in those type of conversations. But also if you look at the graph on the red and gray graph, you can see the sentiment of overall conversation on vaccine trials on social and digital media. And you can see how around that same time, the sentiment mostly became negative. So it was mostly, it took over the more positive and neutral sentiments that were being shared. And if you look at the content, coming back to what I was sharing before, the key content was really about sterility. Why are you testing this in our country with us? And also we've also found concerns about a vaccine being tested in countries that will not be able to afford a vaccine in the future. So why are you testing in populations that will not have access to a vaccine in the future? So we've seen these clusters of conversation. And it's still too early to really understand the full impact that these rumors can have on vaccine trials and vaccines programs. But from our experience of previous trials and previous cases that have happened, we know that there's some potential quite negative impact that we could see, particularly around distrust of vaccine programs, vaccine trials, future participation potentially in COVID trials, but also taking up a COVID vaccine. We've seen that this is not as high as we would like it to be in many countries. But I do want to finish on a more positive note. And I do want to mention that it's really important to do this type of social listening, to be able to respond very quickly. And once we know in real time what are the conversation and the rumors that are spreading, we're able to respond and adapt our communication very quickly. But we also have to see this as an opportunity for us to improve the way we do trials improve and increase local ownership of trials, improve community engagement. All of these are the responses we should be focusing on at this very moment. Thanks.
Thanks very much, Emilie. I think this is very live, and I think the thing about the cycling of older rumors recurring, and it just takes a trigger. I mean, the whole idea of debunking a rumor and thinking it's gone, even if it seems to be gone in the immediate time, we've learned again and again that they sit in the background waiting for opportunities to arise. I think I forgot to mention in the introduction to encourage you to please use the Q&A function, I guess is the best word for it, at the bottom of the screen there. If you would like to send in some questions, we'll have a Q&A following the next session, which would cover questions related to Emilie's presentation as well as the panel. I'll turn over to Beatriz. Thanks.
Thank you so much, Heidi. First, I want to thank the opportunity and the invite to participate in such an important event, and really great to hear about your work, Emilie. This was really, really interesting, and I think a lot resonates to what I'm going to talk about. So in just a couple minutes, again, it's an honor to speak about the report that the Nuffield Council launched in January this year, so it couldn't be more timely. There was around conducting research during public health emergencies, and it was largely based at that point in the experience that we had going through H1N1, Zika, and Ebola. And of course, there's a lot to learn from that and do our best to do better currently during the current pandemic. So I want to focus on one aspect that came out very strongly from this report, and this report was largely based on a consultation, an evidence gathering that involved researchers and survivor groups all over the world, really. Something that really came out very strongly was the importance of conducting community engagement during these trials. And of course, during a public health emergency, there are a million reasons why it would be especially challenging to do so. So we're seeing this now. We've seen that with Ebola. We're seeing this now. There's a rush to find solutions for people, vaccines, therapeutics. There's hardly money to conduct trials and think about conducting community engagement meaningfully. Of course, there needs to be a specific effort also in terms of budget in order to do that properly. And honestly, to speak from the perspective of a researcher in Brazil, and I think it also happens in other areas here in South America, perhaps people don't see the importance of doing meaningful community engagement. Of course, there's levels of engaging communities, and most research is conducted and informs communities something is about to arrive in that community and something is going to be tried. But ideally, some of from what we learned that didn't work so well, what ideally could we do better this time? So how do we engage communities from the beginning of the research cycle? So not only during the implementation, but early on. So of course, there are challenges in doing that too. So for example, now we have, for example, the WHO Solidarity Trial for both therapeutics and vaccines. There are multi-center trials that come in the package. The research protocol is set in stone, and you understand the reasons why, because WHO wants to collect data in a way that results can be harmonized and shareable. But still, even if communities cannot be engaged, and by communities, I guess we want to talk about not only research participants or communities in which the trials will occur, but also the local research groups and researchers, research institutions, local research ethics committees, So how do you really engage them early on, the earliest possible in the conversation for a trial to really be successful and be accepted and so on. So some possible solutions. So from the perspective of research ethics, reviewing research protocols, so they should be sensitized in order to really look for, how culturally appropriate a research protocol is going to be. Really ask for researchers to think through different ways to conduct the same trial so that it makes sense culturally. I can give you a practical example. Emilie talked about challenges in getting meaningful consent from participants in Brazil during the Zika epidemic. There were consent forms in different languages other than Portuguese that were found at people's homes. So you can well imagine how meaningful were these consent processes. So this is absolutely unacceptable. So research ethics committees should be there in order to say, no, you have to have meaningful research ethics consent processes in place. Same for funders. Funders should make sure that there's a line in the budget in order to meaningfully to do some activities that relate to engaging communities from the beginning, and then later on in interpreting the results, and then of course sharing the results. So these are some lessons that I think we've learned that we can try to adapt currently. And again, I guess from the perspective of being in Brazil, there's little literacy really about research, and people have some of the concerns that Emilie just brought us just now. So how do you do that? So we advise on researchers building community advisory boards. So of course, again, in an emergency, that's something sometimes hard to get from nowhere, but there probably patient groups or community groups that you can build upon in order to have in order for these voices to be meaningfully learned. So there are some best practices that have been identified and are there for resource that we can share. And maybe to end on a positive note as well, we need to think about how we can best collect the learning that we're going through right now in order to prepare. So to really think about how do we include community engagement as an ongoing process, that after this big wave goes and we prepare for the next epidemic, how do we make sure that we've learned more, that we've gone a step further in terms of really bringing communities into research endeavors in order to do even better next time. So I think I'll stop here. Thank you again.
Thanks very much, Beatriz. That's couldn't be better punctuated about the community. And I really like your point about the importance of keeping that dynamic going and not just in the moment, because it's not just about the trial time, it's about keeping people engaged and informed. And I like the term literacy. There's been a lot of discussions around COVID vaccine literacy, but I think we have to also think about it as being broader than just the literal sense of reading and writing skills, but having a fluency in the issue. I think we'll now turn to Nellie to bring a bit of the South Africa perspective. Thanks so much.
Thank you so much, Heidi. I really want to appreciate the opportunity. Mine is to just give a real life example of what happens when you have a vaccine and then the mothers have to be vaccinated. So we carried out a study of assessing community perceptions and acceptability of vaccines in rural South Africa as well as urban South Africa. Just as a summary, what we learned was that once you have a vaccine in place, you need to find out who are the key players. So in South Africa, we have a strong public health system and a private health system. What we learned was that the public sector, they're guided by policy that comes from the government. So they vaccinate every pregnant mother with the vaccines that are meant to help the mothers, like tetanus and pertussis vaccines and influenza vaccines. But in the private sector, it's different. Different doctors tell their clients differently. Some mothers do not even get the tetanus vaccine. Probably they consider that not being important. So that was a lesson for us that we wanted to share with this group. And the other thing was that in terms of availability of vaccines, you may have a vaccine in place, but it's not available to everybody. So you find that in some places, rural areas is not accessible because of the structural challenges that people have in the rural areas. And then in the urban sector is also the issue of mothers trying to find money to go to the clinic to get the vaccine or to miss a job, a day job. So it impedes on their socioeconomic well-being. So they have to make a choice in that case. But just to tag along what has been said by Beatriz and Emilie, we find that information relating to vaccines is not available most of the times. So the mothers were always saying that we really don't know what vaccine we're getting and for what. We're just getting a vaccine. So that's for us was a very important point, because if we are developing vaccines and the mothers don't know what the vaccines are for, then we are probably missing something very important. So I wanted to share with this conference about that. And the other side was that even where the mothers were informed that this vaccine is good for you, they didn't understand most of the medical terms that were used. So there's also that level of layman's knowledge versus medical knowledge, which probably it would come into play on the future of the vaccine. So we have to find a way of translating that high-tech knowledge so that people at the grassroots level understand what it is for. And then there's also the issue of guidelines, that the vaccines are available, but then the guidelines are not there. So healthcare workers also, the ones that work with the mothers directly, do not have adequate guidelines or adequate information. So sometimes they don't know what to say to the mothers if the mother asked what the vaccine is for. So that is also something that we have to pay attention. It's probably an issue of healthcare system challenges, but it's something that needs to be addressed. And then there is also the issue of stockouts. Sometimes the vaccines are not available, even if the people want them. There are challenges in making sure that there's availability of all the vaccines that the mothers need in the clinics. So we saw that there are some challenges, but there could be a few solutions that we suggested. And the following solutions were suggested, like to standardize the procedures between private sector and public sector, so that if a mother goes to public sector, she will get the same treatment or the vaccine that she would have gotten from the private sector and vice versa. And the other thing is just to make sure that Department of Health, in our case in South Africa, has all the relevant vaccines that are out there that are needed by the mothers, and that information is shared and on a regular basis and evaluated if it's making impact for the mothers to be able to access the vaccines, and also that it will help the mothers be empowered to know what they're getting, so that they don't have to wonder, what is it that I'm getting? I do not know. So what we would say is that community engagement is important as well, because if we have information flowing freely in the communities about the vaccines that are available and the type of vaccines the mothers would get, would actually take out all the challenges that the mothers are experiencing. So that's one thing that we can take from here, and also to improve on the literacy of vaccines amongst communities. Thank you very much.
Thanks very much, Nellie. And I think you make some good, excellent points across a number of different issues, from access and translation, and also the importance of embedding it in the community. We'll turn now to Primus to talk a bit from the Kenya perspective, and then we'll come back to overall Q&A, some of which have been coming up on the Q&A chat section. Thanks. Go ahead.
Yes, thanks Heidi and team for the invitation. I'm glad to be part of the conversation. And what I intend to share is our experience with undertaking challenge studies in the context of Kenya. And I should highlight that what we have been doing here are mainly challenge studies for malaria. So I would draw on the experiences we've had and highlight how those experiences could also contribute to any potential challenge study, perhaps in the context of COVID. So we know challenge studies involve deliberate infection of volunteers with a well-characterized strain of an infectious agent using a controlled dose, controlled environment, as well as a specific route of administration. And they seem to be quite helpful in enhancing knowledge about pathogenesis of diseases, as well as expediting the process of vaccine development. At face value, such ways of doing research raise a lot of social and ethical issues, especially the issue of deliberately infecting someone, which at first value will go contrary to ethical principles like non-maleficence, that's do no harm. And on the social side, it can actually raise a lot of rumors and misinformation, which may have other long-term effects with other health-related research, which is being done in the same context. And in the context of Kenya, like I mentioned, we have worked mainly on malaria, and we have some at the site at the KEMRI-Wellcome Trust research program. There's this long-term experience of undertaking these studies on malaria, and we have a long-term experience also on building community engagement platforms that engage with the communities in which these studies are undertaken. And like Beatriz and Nellie mentioned, the community engagement is a very critical issue here. And I will say, on the side of the volunteers, it's really important for them to understand what they are engaging in. And on the side of the public or the community, it is also important to keep that in mind, because the experiences that the volunteers that have gone through these studies and they are back in the communities, the experiences that they share with the community could have a lot of ramifications on the public perceptions of such studies, and even on the products that may even emanate from such studies. And a key thing to keep in mind in this in the context of COVID-19 is if such studies have been undertaken, which some people are advocating for that. And I will also highlight that there are others that have been resisting such moves, mainly on the fact that there's no rescue treatment at the moment, and the fact that the mortality and mobility associated with COVID-19 is quite much. But I want to highlight in the sense that in the case where these issues have been addressed and you have to run such studies, community engagement will really be critical, because the experiences that those that eventually enroll in such studies and go through, those will be the ambassadors that will spread the information in the communities, in the public. So if the community engagement and the informed consent process is not effective, at the end of the day, it might end up having the unintended effect that the stakeholders may intend to achieve. Then one thing I should also highlight is still in the context of COVID-19, if such studies have to be undertaken based on existing guidelines from the WHO, it is important that such studies should be done in a developing context where the health systems are strong enough to better manage the side effects that may come from the vaccine or from or COVID itself. And when we have learned from that, then that is when we can start thinking of a possibility of doing it in low and middle income settings where the health systems might not be very strong, and yeah, to handle the fallout of such vaccine studies. Yeah, so that's where I will end for now, and I'm happy to see what comes up from the Q&A session. Thank you.
Thanks very much. We do have a number of questions coming up. Some of them are being answered directly by the panelists, but let's see. There's a question here to Beatriz. Let's see. Are there any COVID vaccine related fake news or social concern studies being done in Brazil or that you're aware of in Latin America? So studies about the phenomena of fake news or social concerns around COVID vaccines.
Yeah, thanks for the question. That's very important. And it's been a major issue in Brazil, fake news around not particularly vaccines necessarily, but about the disease itself, and very much on the lines of what Emilie presented. There has been an issue about that. The Ministry of Health itself has been trying to have an updated database of these fake news online. So if someone from a community can get online onto the Ministry of Health website to look for a given information. So there's something that's being updated daily, I know of. And I believe, I'm not aware of any specific studies on that, but I believe they'll probably pop up. In terms of vaccine, related specifically to COVID vaccine trials, there are two major trials that have already started recruiting participants in Brazil, both phase 3 trials, and that are recruiting healthcare professionals. So I think the whole, the vaccine hesitancy for this group in particular might be different. The issues related to that might be different to the general community. And people have been signing up for these trials massively, really. So there has, but again, it is a very particular group. Of course, it's people that are heavily exposed, that are on the front lines, either by being healthcare professionals or people as staff at the hospitals, so these people have been looking for the vaccine. But I assume once this target group moves on to reaching the community, where again, literacy around vaccination in general and the disease is probably going to hit different issues and different challenges. But so far, I guess, because it's, again, targeted to healthcare professionals, that has not been an issue. Quite on the contrary, people have been signing up, and there are thousands of potential volunteers for the trials currently. And again, once we move forward, I guess there will be different challenges ahead. But this is what's the scene now. But thanks for the question.
Great, thank you. Well, it's good to hear that there's an enthusiasm for the trials. That will be helpful to move things forward. But and we will have a look at the Ministry of Health site. But also, I think it's a good idea if someone is someone starts a study following this phenomena. We have another question about subnational measurement of vaccine confidence for countries like Nigeria, India, Brazil, Indonesia. I know at the Confidence Project, we do have them for Nigeria. About to start some state-level studies in India. And Brazil and Indonesia, we are just starting more specifically to COVID confidence, but not, I mean, we have national level confidence levels for Brazil and Indonesia, but not nuanced at a more local level. But let's see what else we have for the panelists. Which countries are covered by the Digital and Social Listening Project? I assume this is probably related to Emilie's. This is specific to the trials. I know that from the Vaccine Confidence Project perspective, we do it globally in multiple languages on vaccines more broadly, but I assume that the question is relevant to the trials. And Emilie, I think this is related to the countries covered in that you referred to.
This is it was a global analysis of multiple countries, but with a strong focus on African countries. So it's a long list of countries that I'm not able to go through all, but we had, for example, Nigeria, Kenya, Ghana included, the Gambia, South Africa, but also some countries in Europe, the US. So it was quite a range of countries globally.
Thank you. I'm just reading through a couple more questions here. When and if COVID vaccine becomes available, how are we going to be prepared? I think there are a lot of discussions about this right now in the broader community. I know the Confidence Project is involved with a new initiative that's being launched called Convince. If you go to our website and look for Convince, we talk a bit about it, and that's with a few partners. But I think as we get more information, as there's more attention to the trials, there's definitely a number of groups, and certainly at local level, there are plans in the work. It's quite different, and we're in discussions also with Africa CDC, Africa Union. One of the phenomena in terms of preparedness for a COVID vaccine is that in a number of settings, we still have quite a bit of denialism that COVID even exists. And if we don't, and that why people are getting more sick and dying is for reasons other than COVID. We've seen that particularly in a number of African countries, but also I think in Brazil too, that was happening, and certainly in the US and some other places. So if people don't believe that COVID is the level of threat that it is for not only illness, but death, it will be difficult. I mean, they would find no motivation to take a vaccine. So I think we need to look at the bigger picture, and that's another of the various discussions. A good question about vaccine hesitancy beyond trials. Are there community-based tools or frameworks to address vaccine hesitancy? I'm not sure if this question means about addressing hesitancy that erupts in a trial and how to keep attention to it, in which case I think, Beatriz, that gets back to I think you raised that the importance of keeping that, and Nellie, I think might have also mentioned, I can't remember, in the discussion, it was suggested in one and said more explicitly in another, the importance of keeping that dynamic going. I know with the Ebola trials we're working on, we definitely are kind of hand in hand with communities, because certainly if the trials go well, we do want the community and outside of the trial to also be engaged in learning, because then when the vaccine is available, publics don't really like surprises when it comes to vaccines. So the more we bring them along in this process of the trials, now is the time to start with COVID preparedness, absolutely. Even, what are the options out there? What stages are we in? And the more they feel like they're coming along with us on the process, the more likely they'll at least won't feel like it's being hidden, which has been a bit an issue with a number of trials. There was a concern about this is, sorry, a lot of questions here. What's up? Facebook, Twitter spreads fast and generally contains misinformation. Is there a central group related to vaccine confidence that can be used as a resource? Videos or short infographic memes? I wouldn't say there's any one central source. I mean, I think there are a number of us trying to address this. But I think I'll turn over to the panelists. There are quite a few local efforts in different settings. One of the challenges with What's Up, for instance, is that it's closed groups. But Primus, Nellie, Beatriz, do you have some local examples of how this is being addressed? I mean, we have some of our own approaches, but I'm very interested in your perspective. And as is the question.
Yeah, I guess that's a really good question, and it speaks to the bigger picture that you just described, Heidi. I think in a country like Brazil, where we had politicians really discredit the disease, it was really up for the civil society to try to organize itself and mitigate the very heavy effects that these comments on how it wasn't really a big issue. And so again, as you said, I guess there are different groups trying to work on that and trying to be creative about it. There are some that we can look for and share. Of course, they're in Portuguese, but again, they come from university. I know, like the university where I'm at, it's a public university in the city of São Paulo. We have an Instagram account in which we do have infographic, and we try to translate information that's very like high-tech scientifical into language that anyone can understand. So we produce materials, for example, on COVID testing, because there's so many different tests. People get confused. What I'm getting tested for? What does this result mean? So I was personally involved in this project of trying to bring this language, to a tone that it would be more, at people's grasp. So, but these are, as you said, Heidi, there are different groups trying to work with the same goal of mitigating fake news, trying to bring literacy to the larger community. But I guess there are great examples. There's more internationally, there's the MASH platform. I don't know if people are familiar with this platform, but it is a platform that really aggregates resources for community engagement, and it does have a specific page on COVID and resources for COVID in general, not only for research, but also, you know, engaging communities and increasing literacy. So MESH is a nice place to check.
Great, thanks very much. I think our Nellie or Primus, do you have any quick responses? Otherwise, we can move to the next session. But
yeah, I think I would just add to say that the community that we're working in, we do have a lot of resources that are coming from government. So in South Africa, the government has taken control of the information sharing. So if you find that you are sharing fake news, then you could be arrested for it. And a few people have been arrested for sharing fake news. But what I want to emphasize is that also that the community, because it's a new disease and everybody is learning, they always ask for information. So our site, we normally have some updated information that we share with them through radio, TV, and also leaflets. We give them leaflets to know about the disease and how to prevent it. But in South Africa, it's very well controlled, that a lot of people know how serious the problem is, and there isn't much denialism about it. Yes.
Yes, and just to jump in the case of Kenya, also the government is quite in charge of most of the information given. We have daily briefings from the Ministry of Health on TV. So that information, I think lots of people listen to it. And there's also a law that also penalizes the spreading of fake news. And I think a couple of people have actually been caught with that. Then at level of the program, the communities we work in, there's a huge network of community representatives that our community engagement platform actually liaises with them on a regular basis to get a sense of how things are happening in the community, but just to but not to give information on COVID, because that is the responsibility of the government. So. Yeah. And also we have radio programs that we also target those communities, mainly to talk about ongoing research that is being done by the program within those communities. So nothing happens there when the communities are not aware of. So. Yeah, over.
Great. Thank you. Okay, we'll move on to some, and this is a good transition, because I think the next session is very much talking about the engagement in communities. Happy to introduce Robert Kanwagi, is Program Coordinator for EBODAC, which is the consortium I mentioned at the beginning, Ebola vaccine deployment, acceptance, and compliance. This was particularly around a 2-dose vaccine that the consortium got going, but now is contributing to other trials. And Mateus is a medical doctor and initially was working more as a clinician, but has become quite sensitive and aware of the engagement issues with trial participants and community, as in doing more and more with communities through the Vaccine Confidence Project and EBODAC. So over to Robert.
Thank you, Heidi, for the introduction, and thanks to my colleagues, the organizers of this webinar, and the presenters that came before me. We would like to share some of the work we have done in Sierra Leone, DRC, Rwanda, and the experiences that come through that. Myself and Mateus have both worked on the Ebola vaccine. Both worked on the Ebola vaccine trials in Uganda. and presently we are both working on the Ebola vaccine in DRC. I think we need to begin by looking at these three words: rumors, myths, and misconceptions. I'm not going to read them, but once we understand what they are, then we are able to tell what's likely to come as a result of the challenges that we face when we talk about vaccine deployment. From our own experience during the Ebola vaccine, these are some of the reasons that rumors surface during the clinical trials, or even during the studies, or even during campaigns. EBODAC has gone through an evolution of supporting trials, then supporting studies for Ebola vaccine, and then supporting the campaign in Rwanda.
Robert, just 1 second. Could I please ask all participants to put on mute when they're not speaking? It's interrupting the presentation. Thank you.
Interrupting. So the common causes of rumors that we have witnessed during the Ebola vaccine trials, studies, and campaigns is basically the uncertainty, and you can see it even now with the COVID-19. The others is people just feeling anxious. Again, this is common with the COVID-19. People spread rumors when they think the information is important. This week we have seen one particular case of this that has become so sensation on social media. Many of you should have watched that video because people thought this information was important, so they kept on passing it on. The other causes that we have witnessed in the field that are causing rumors is people simply believe these rumors, that this is actually true, and they are willing to pass it on. Some people just pass rumors to help themselves. Again, this happened during the Ebola vaccine trials, but you have also witnessed it during the COVID pandemic, where people are simply passing rumors for their own benefit. And of course, some people just spread rumors when it helps their social status. This is true. Some people want to be seen like the originators of information, or the originators of a sensational video about something that is going on at that time. So we need to understand what causes rumors if we are going to address rumors. And then these are some of the things that could be a consequence of rumors. And some of these we have witnessed in DRC. Loss of credibility, people no longer believe in the trials of its purpose. There have been some cases of this where there are struggles if there are two trials going on or two vaccine deployments going on at the same time. There are issues of trust. Rumors also affect participants' recruitment, but also rumors affect participants' retention, especially if you have a two-dose vaccine like the one we have been working on this project. We have also witnessed what we call the evolution of rumors. Rumors can happen pre or during the development of the vaccine or approval. I don't think that for the Ebola vaccine, when it was being developed, the world knew a lot about the development of the Ebola vaccine like it now does about the COVID-19 vaccine. So the Ebola vaccine may not have suffered a lot of rumors before the trials began, but the COVID, as we all see, is already facing millions of rumors on social media every day. Rumors could also be exist during the trials, and this was the case in Sierra Leone. There were definitely some rumors. For instance, there is a common rumor about withdrawing blood and taking it out of the country to sell it. There is a common rumor that was spreading in Sierra Leone that this was just a trick to kill Africans. So that came up during the trial. And as you can see from my presentation, for every time you do not address a rumor, the rumor will shift into the next phase of the deployment of the vaccine. If you don't address rumors during the pre or development phase of the vaccine, these rumors will simply move and transit into your clinical trials and studies, because they are being picked up and translated back down as you move towards the cycle of the deployment of the vaccine. If you don't address rumors during clinical trials and studies, you are definitely going to face the same rumors when it comes to the vaccine deployment or administration. And if you don't address rumors during the vaccine deployment and administration, you are definitely going to face the same rumors when it comes to the post-administration and deployment. So it is critical to map out the different stages when rumors evolve and address rumors as they come along. Now, how can we proactively engage communities to mitigate the spread of rumors and build resilience and confidence? We believe, like we have done with the EBODAC project, that there should never be any trial without community engagement from day one. And day one here, we don't mean the day the vaccine lands in a country and you begin the phase 1 trials. We believe that community engagement should actually exist in terms of citizen participation and feedback and engagement, even during the development of the vaccine, so that communities are kept informed about what is being done, so that all these rumors about what is being developed can also be managed at that level. So for us, the bullet point in the EBODAC was there should never be a trial without community engagement. And therefore, one of the key recommendations that we would suggest and always advocate for, that before you begin any clinical trial, let the community engagement be your entry into that trial, and it needs to happen before the trial begins and continuously throughout the trial. The other thing that we can do to be proactive in communication and community engagement with communities is, again, a result of learning from the Ebola vaccine trials. We have been able to develop a tool that we did not have in 2015 that is now available. You can conduct what we call a 3 C's: communication, community engagement, and compliance analysis, so that you identify what are the weaknesses and the strengths in terms of the 3 C's of the communication and community engagement, which is basically the demand side of your vaccine trials. Identify those gaps and then use those gaps and strengths to come up with a robust communication and community engagement strategy. This is what we did in DRC when we were developing the communication and community engagement plan that we have used. There was a question on the platform where one of the participants was asking, is there a tool that can inform? This is a good tool that could be used to inform development of communication and community engagement plans, but also inform research that needs to be done to understand the issues better in the community. The other thing that we have learned from the Ebola clinical trial is that you need to put in place a communication channel and a guideline to standardize the communication to the community. You do not want to have your different frontline soldiers or health workers communicating different messages to the community to create confusion. You don't want rumors to come from your miscommunication. So can you make sure you standardize the communication and have guidelines for that? In DRC, Sierra Leone, and Rwanda, we have had flip charts, and we have had also communication fact sheets in terms of questions and answer, Q&As, which guide how do you answer this question and what is the appropriate response to this question. Then you train all your frontline workers. In case you come across this question, this is the right way to answer this question, or this is the acceptable way from the community. You can even pre-test. That is standardization of communication. The other key thing that we have learned from the Ebola clinical trials is that you need to do a social and political analysis to define effective roles for authorities. This is critical because it helps you understand all the key stakeholders in the communities, their levels of influence and authority, and how they can be useful in navigating the challenges that you like to face with ensuring community participation. The other thing that has been a success and we would recommend from the Ebola clinical trials that we have learned is the importance of integrating social science into research and communication. Yes, these two can be standalones, but how does your social science in your clinical trials inform your research, but also inform your communication? In Sierra Leone, we had a social science team and we had a community engagement team. But whatever the social science team picked from the communities, they would share that with the communication and the community engagement team. And they used to have coordination meetings and sharing meetings and development of messages. The other thing that we have learned that can cause proactive communication and engagement is dialogue. Of course, coming away from the old school information overload and dissemination, where we printed messages and just threw them to the communities, or conducted radio talk shows and spoke to the communities. In vaccine trials, again, learning from the Ebola vaccine trials, that EBODAC has supported dialogue, which is basically listening to the public and the communities to understand what are the issues and what are their concerns, and then using that understanding to develop appropriate means to engage them, has been very key in the success of our deployment of the Ebola vaccines. Another one which has already been talked about is about digital and social media monitoring. Emilie has talked about this, but this is also key. You don't really need sophisticated hardware for you to monitor what the rumors are. Even Google, if anybody who has a smartphone, there are some Google tools that are available to you on your phone that you could use to just monitor what is being written about the Ebola vaccine, for instance, in DRC, or what is being written about the COVID-19 vaccine development. And then you are able to develop appropriate messages that can counter any rumors and misconceptions out there in the field. We have also used in the EBODAC project and Ebola vaccines enabling technologies. Mainly here, when I talk about enabling technologies, I'm talking about keeping a constant communication between the clinical teams and the participants that have volunteered to take the vaccine. For instance, the vaccine that we have been deploying in Sierra Leone, DRC, Rwanda, and Uganda, there is the difference between dose 1 and dose 2 is 56 days. How do you ensure that your participants actually know their return date? We were able to map out for every participant that came into the clinic their return dates using digital platforms, and these participants would get a message prior to that date when they are required to come back and do their boost vaccination. That reinforces the engagement. So you communicate with the participant after they have got the vaccine and continue the engagement until when they are able to come back to the clinic for their boost vaccination. But also you can use it as a map to map out. You can use it as a tool to map out which communities have least compliance. In terms, you can come up with a map that shows you this community, a lot of people have not come back for the boost. Therefore, you target your communication and community engagement plans and tools to that particular community. That's what I call purposeful engagement. The other thing which is key to building resilience and confidence in the vaccine, it's very important that as we do all these trials and vaccine deployments, we try to build on existing community structures. Sometimes when trials start or vaccines are being tried out in countries, they come with their own structures, and that's part of what creates community suspicion. Why do you want to run a program parallel to an existing program? And what is the secrecy of you trying to do something different from what we're used to doing? So one of the things we have learned, and we have done this wonderfully well in Rwanda and DRC, where we have worked with the health communication commissions of this country, worked with the government health structure from the top to the community level, used the health structure of the government to ensure that it is trained, they know what their role is, and they are the ones involved in both mobilization and the administering of the vaccine. So can we build existing community structures and build their capacity to lead and build community partnerships and trust? There is a question on the chat which talks about journalists or the journalist associations are part of the community structures. Can you also do that as part of the mapping and train them in the information that they need based on their gaps? So that's part of the structure that we actually trained in DRC. We trained some of the prominent journalists and radio hosts who had been talking about Ebola in vaccines in a very negative way because they lacked knowledge on what they could communicate. The other key thing that we have done during the Ebola vaccines is active rumor management mechanisms. So are we able to detect, identify, analyze, and respond to rumors when judged necessary? This you can do by using, of course, the social media monitoring tools, but you could also use the community tools which are available to you. In DRC and Rwanda, we have been able to set up community listening posts and community listeners, people within the community that hear what's going on in the community, observe what's going on in the community, and they are able to inform the community teams what they are hearing and what the suspicions of the community are. Therefore, you are able to preempt any reactions from the community because you're listening to them and you are engaging them to solve any issues that could be creating mistrust. So that is also part of what we call active surveillance and listening teams in the community and getting that feedback that we require. In DRC, Rwanda, and Sierra Leone, even in Uganda, we have deliberately created community reflections and review platforms and representations. For instance, we have participants advisory groups where participants who have taken the vaccines within themselves will form a group with clear guidelines to represent fellow participants, and they can talk to participants and get their views about what are the challenges they are facing, what are their fears about taking the vaccine, why are other people not coming to take the vaccine, and then they would come and talk to the clinical teams and share this information and work together to come up with strategies to address any concerns that are coming out of the community. So you need to be very deliberate in creating, again, those structures. It is always good to use existing community structures. Another key one, which we can already see with the COVID-19 vaccine development, is how the COVID-19 vaccine is taking a religious or faith angle. There are many people who are now talking about the vaccine based on their faith. This is what my religion says. It has worked for us so well in the Ebola vaccine trials, studies, and campaigns in all the 4 countries I mentioned, where we have deliberately had a faith and religious leaders engagement strategy to address any issues of faith, religion, and vaccines. This is basically trying to understand what does this particular faith say about vaccines and why do they think or say it that way. And then using the experts from the clinical trials or from the science world, we're able to find a common ground of understanding and inform them so they then become champions or agents for people to come and take the vaccine. We also have learned from the trials and studies and campaigns that it is always good for you to adhere to ethics in communication and community engagement. Issues of data, issues of child protection, it's very critical that these issues are addressed as you do communication and community engagement so they do not become obstacles or limitations for you to be able to engage the communities and mobilize them to come and take the vaccine. We have also learned that with vaccine trials, there will always be something unexpected that will happen. Always have your crisis communication plan at hand. Know who should be your official spokesperson in case there is an issue that has come up. What is the message that needs to be communicated? Ensure that that message is pre-tested and signed off by relevant authorities before it goes out. Because if you mismanage a crisis during vaccine trials, then you are not helping build resilience and confidence in that particular vaccine. And you're likely to have a lot of resistance from the community. So those are some of the experiences that we can share in terms of communication and community engagement and proactiveness. And my colleague Mateus is available to provide more answers to the questions that will be coming from this discussion. Thank you very much.
Thanks very much. Mateus, do you have any initial comments before we open up to questions?
I want just to add two things. The first one is that especially about vaccine trial, we are dealing with people who are healthy. So it's become more easier if you are targeting people who are sick, because they are sick, they are seeking for care, then they can they can accept easily the vaccine or the product. But for vaccine, it's very difficult because people are not healthy. You have to communicate with them, you have to engage them to make sure that they are convinced to come to the vaccination center. So it's become more difficult, and the community engagement is very, very important for that. And also the other thing is that I want just to reinforce what Beatriz said, that usually when people are planning for a clinical trial, they just plan for the protocol and nothing else. They don't think about the community. And usually you'll see that there is no budget for the community engagement. And then when you are implementing the activities, you are struggling to implement these activities for community engagement. It should be very important that this should be really taken into account and make sure that the community engagement starts well before the vaccine, the trial can start. So this is very, very important. And also we have to make sure that people are getting the right information, because the issue is that when people are getting ambiguity, uncertainty, they try to find themselves information the way they want, and then it's become rumors. So we have to make sure that we have people on the ground who will be able to answer all the questions, all the concerns that they have, so that they can get the right information.
Thanks very much, Mateus. And I think that your point is really important, that it's the usual according to protocol. That even happens sometimes when you do have community engagement. There is a plan that is as if support for things going normally, but just to get engagement around that. But as Robert said, sometimes even when you have the engagement, you haven't thought about if there's an emergency or if things go off protocol when you don't expect them. I think one other point that I just wanted to bring back was the social political analysis that Robert talked about, because typically you want to find influential local leaders to be supportive, but sometimes that's not the ones who are leaders according to their political role, but basically who do people trust. And that may not be the religious or political leader by their title. And we've learned that in a number of our trials. You need to learn from the community who is the trusted one amidst the various roles in the community. Over to questions. We have quite a few. Let's see where we can start. Sorry. I think there has been a question about monitoring rumors. That is this passive or active? The concern being that by being proactive, you might trigger rumors. Certainly in our case, it's much more passive, either people in the community, a network of what we call listeners, and in the case of online, we're not, we have a mix of search terms, and it is passive because we do try to be very conscious to not fuel rumors and concerns, but actually listen to them. Here's a question. Some vaccine researchers fear that by investigating a rumored concern, oh yeah, this was the one you just said. Concerns about the speed at which the COVID vaccine is being developed and safety concerns. We've heard that from a number of places. I guess that I think one thing that's come up a lot in our discussions around that outside of this meeting, this webinar, is that we need to do a better engagement about why the COVID vaccines are able to be done at a slightly faster rate than normal, because we have funding mechanisms we didn't have before, and that was thanks to Ebola that prompted that. We have new technologies that allow this to happen, and we're not just shortchanging an old session. And I think one of the questions, another, was how to best communicate the fact that there is a potential risk associated with the vaccine for COVID, as it's so early and we don't have enough information. How do you manage uncertainty? Robert, Mateus, you know, with the Ebola vaccine, we've had a number of issues. It's, you know, already the Ebola as a virus has been quite a frightening phenomena, and then to ask people to take a vaccine, how have you in the community and talking with people, can you give advice on managing this kind of uncertainty?
Yeah, so I think, as I said before, it's just to make sure that you are giving to people the right information, and also make sure that you intervene, not waiting for so long when the rumor has spread for a long time, and you pick it at the right time and then give the right information. That's what is very important. Because with Ebola, at the beginning, people were thinking that it's just a political issue, so it's not really a real disease. And when it comes to when there is a conflict in the countries, then it becomes very difficult. And also the source of the information is very important. So make sure that the information is coming from someone that the community can trust. So that's why we try to create a group of people who can be in the community, listen to people, and then give feedback. And then we try to see together and concept the right message that these people can give to the community. What's important is to make sure that when people have questions, they get answers to their question.
I think, Mateus, you said really that's such a crucial thing, and we see that with vaccines more broadly, that when publics feel like you're listening and willing to answer their questions, you already can slow down the spread of rumors, because they're not going to other places trying to find information because no one was there to give them the answer to their question. So timeliness and being responsive. Absolutely. Robert, do you have any thoughts on this one?
Yes, I think there is no shortcut when it comes to giving facts to communities. You don't want to say, okay, this vaccine is under trial, and if the community is questioning, why are you giving me something that is under trial, and you're not sure that it will be approved, because this is one of the main questions that will come to the community. Okay, the vaccine is here, but you're telling us this vaccine is under trial. It is not yet approved. What we have done from Sierra Leone to Rwanda to Burundi to Uganda, to Rwanda to DRC to Uganda, is to tell the communities how the process that the vaccine has gone through to where it is, the benefits of them participating in the vaccine trial, and the facts around what safety measures we have seen from previous studies, so that we build their trust for them to understand that this is a vaccine not yet approved, but has been reviewed at all levels to ensure that there will be safety. Also, to ensure that we also assure them that during the entire process of the trial or the study, that the providers of the vaccine will do everything possible to ensure their safety during their participation in the vaccine. And also to re-emphasize that it is up to the participants to choose whether to participate in the trial or not to participate. It's not mandatory, it is their choice. When you have a conversation where the communities feel they have all the information, it is up to them to decide. You are building that trust where they will be willing to participate in a trial, to give back to their communities, but also to give back to the world, than when you take a shortcut of maybe misrepresenting facts. So the bullet point here for me, give the facts, be transparent, be honest, and then you will create the trust that the community requires to participate in the trials. We have not had seriously any resistance to acceptance to take this Ebola vaccine since we started. In Sierra Leone, we had more numbers than we wanted for the vaccine. In DRC, within 3 months, we had vaccinated 20,000 volunteers, people who have freely made a decision. In Rwanda, they are moving at a very terrific speed. They are going to vaccinate more than 200,000. In Uganda, the same. So as long as the communities have the facts and you're honest about what you're communicating and you're consistent about what you're communicating and you're involving a bigger community structure that can reinforce the message, they will always be willing to participate in
Yes,
most
I
of
can.
these trials.
I think we should add in each of those settings, the community engagement started well before the trials even kicked off. And I think that that was the success of those acceptance. Robert, I have to thank you and the collaborative work to have made that success possible. We've just got one more, well, there's more than these questions, but for anyone whose question hasn't been answered, please feel free to email us at the Vaccine Confidence Project. But I will just throw one last question out. Do any of the panelists have experience with successful trainings for journalists to help with community outreach of positive trial messages? And is this an effective strategy or better to engage directly with community members? In my personal experience, I wouldn't say it's an either or thing. You certainly need both. And I've also found in any of the journalist trainings that we've done, journalists want to investigate the situation, but I've heard them in a number of settings saying, we don't work for the government. We don't work for, the university of wherever. We're working to investigate the issue. So sometimes they get a sense that they're being told that they're the mouthpiece of the government or whoever, and well, depending on the country, they want to actually bring a more independent. So I think rather than thinking of it as journalists to spread the positive message, journalists can also bring to the picture some of the questions they're hearing from the public, and it's an opportunity to be responsive through journalists to the emerging questions from the public, in addition to getting the facts out there right. But do any of the panelists have a quick last word on engaging with journalists in the context of trials? And then we've just got a minute or so to wrap up, but any last word on that we'd welcome. Even Beatriz, Primus, Nellie. If not, have a welcome back.
No, I think you've said it all, Heidi, and I think similar to what we've been talking about, these efforts as being continuous. I think as long as we engage with media continuously, not only when we're living this crisis, I guess we'll be better off, right? And it's a matter of it is a partnership. Really, I guess our overarching goals are the same. There's no magic behind it, but I think if we do it, continuously, we have a better chance to succeed.
I think thanks very much. I think that's a great note to end on, whether it's journalists or community members. The idea is not to jump in just in the moment and then be gone when the event or the trial is over, but that this is a relationship that the more ongoing it is, the more those trust relations are there with journalists, with community leaders, religious or political, and that will be the assets you bring to any trial. Thanks to everyone. Special thanks to all the panelists. We're really grateful that you took the time, and I'm sure the participants who've signed up for the webinar are also appreciated. Thanks again. We will have 2 more webinars related to COVID and vaccine confidence in September. We'll keep you all posted. We wanted to give a month pause because there's a lot of, it's a very dynamic space around the vaccine, and we thought that come September we'll be a bit closer with some hopefully new information, and we can regroup then and see what we can bring to these important discussions. Thanks, everyone.
Thank you.
Thanks
Thank you
all.
too.
Great panel.
Thank you very
Bye.
much.
Thank you, guys.
Goodbye.
Thanks.